रोटी खाए बैठने में
Hey, hello. Hello.
Hello, I'm going to start in about 9:15.
Oh, okay.
Has
Okay.
the session stopped?
I'm sorry.
Were you on the previous session?
No. I was
Okay.
just on the website and then I saw that there's a live going on and I click on it.
Okay.
Okay.
There's a previous session before this one, and I'm giving people time to get on this one.
Oh, okay, okay. Thank you.
Hello, everybody. This is Dr. Lapage. We're going to go ahead and get started. I was trying to let anybody who was on the previous session time to join us. So we're going to talk about endocrine medications tonight as part of the pharmacology lectures. And let's take a look at our outcomes. We're going to differentiate between the types of diabetes and the treatment for each. Apply the pharmacological principles of insulin and those anti-diabetic oral agents to the care of the patients with diabetes, and then apply the nursing process to the administration of these agents, and then evaluate the effectiveness of these pharmacological therapies while we're providing education to the patient. We're also, going to talk about some of the thyroid medications and medications that are used for thyroid disease. So, kind of did a comparison here of type 1 and type 2 diabetes. The pathophysiology is a little different. In your type 1 diabetics, there is no insulin produced by the pancreas. It's caused by an autoimmune destruction of those pancreatic B cells, and it accounts for 5 to 10% of the diabetic cases. Excuse me. Type 1 diabetes usually is diagnosed in children. Children typically do not ever get type 2. Type 2 is where the patient has a decreased amount of insulin produced by the pancreas and is characterized by insulin resistance or deficiency. So there is some insulin being produced, but it's not enough to keep that blood sugar at an even state. It does account for about 90 to 95% of the diabetic cases that we see, and it typically occurs as people age. Could occur, there are some rare cases in your young adults, but we typically see it more so as patients become older and they're probably late 30s, 40s, and then as they age even further. Now, type 2 diabetics can then have to progress to taking insulin. The difference between the two is the treatment. In your type 1 diabetes, these patients require insulin replacement. So they're taking insulin from the start. Type 2 diabetics are going to start on those oral anti-diabetic medications, may have insulin added, or your newer classification of medications that have come out, your GLP-1s, that are proving to keep that hemoglobin A1C down, and patients can decrease the dose or stop taking their oral anti-diabetics altogether and stay on the GLP-1s. Body system damages, again, think about the age group of the patients that are diagnosed. And those type 1 diabetics tend to have more complications at younger ages. So they tend to get that neuropathy, glaucoma that can lead to blindness, hypertension, coronary artery disease, and then kidney and renal failure as young and middle aged adults. Your type 2 diabetics, it does tend to take a little bit longer to develop these, depending how now, that's not to say that they can't develop these complications quicker if they're not managed correctly and they're not adhering to the medication management and those lifestyle changes. So, there are some lifestyle non pharmacological treatments that both type 1 and type 2 diabetics can try and start, or to help decrease that hemoglobin A1C and keep that blood sugar more even. Can do some lifestyle changes, decrease their sugar intake, eat more complex carbohydrates, decrease their simple carbohydrates, and increase their protein. A lot of blood glucose monitoring for both, especially your type 1s. A lot of times these patients are now on those 24-hour glucose monitoring devices, or until they can get to that point, they're doing a lot of blood glucose checks during the day. So think about they have to carry their equipment, they have to have it with them, and a lot of finger sticks. So they can tend to get some calluses and painful fingertips. Exercise can help, especially in your type 2 diabetics, and then weight loss and your GLP-1 medications for your type 2 diabetes. Your type 1 diabetics are not able to take your GLP-1s. Does anybody have any questions so far in the differences between the two types of diabetes?
Uh, Professor, type 1 is genetic, right? Like from family, right?
It can be, yes.
Oh, there is other way to get type 1?
What do you mean another way? It could be it's an autoimmune destruction of the pancreatic cells. So most often it is, but your older adults can develop type 1 as well, where their body stops producing insulin because of the progression of the disease, and they may need to be on insulin. So they can have a type 1 and a type 2 in your adults.
Oh, okay, I didn't know you can have like both at the same time.
As they age, they can develop and need to have insulin in the type 2 diabetics. If their blood sugars are not completely controlled, your type 2 diabetics, they may need to add insulin to control the blood glucoses. But now they've got a lot of those GLP-1 medications that have come out that tend to work a little bit better and control those blood glucoses and keep them stable.
Okay, thanks.
The type 1, somebody put in there, which one is more of genetics? It is type 1 that is more genetics. So there are some risk factors for type 2 diabetes. It's obesity, impaired glucose tolerance, insulin resistance, the ethnic background, sedentary lifestyle. A family history can be in type 2 as well, which has to do with genetics. And then the age. Typically, they're over the age of 18 and an adult. Those patients who have polycystic ovarian syndrome are also prone to type 2 diabetes. Give me just a minute, please. I need to fix. I'm sorry, y'all. I was fixing my slides. Polycystic ovarian disease can predispose patients to developing type 2 diabetes, and they actually manage polycystic ovarian syndrome with metformin, which is an oral anti-diabetic that helps the patient possibly conceive for pregnancy. I saw a question in NASLEX and it was type 2. Which one is more genetic? I was confused. So type 2 can be genetic or acquired. Yes, type 2 can also be genetic and have family history predisposes them to type 2 diabetes as well. I saw a question in NASLEX and it was type 2. both of them can be genetic. A lot of times your children of parents who have had type 1 diabetes tend to develop it as well. I have a family that we know. The dad has type 1 diabetes, has had it since he was a child, and the son developed it at age 6 or 7 and was really what we call a brittle diabetic. They couldn't get the blood glucoses under control, spent a lot of time in the hospital, and then they tested the daughter for it, who then tested for, or they did genetic testing and see if she would be predisposed to getting type 1 diabetes. She was 2 years older than the son, and at age 10 she developed it. So there's your genetics. The dad had it and the 2 kids. Type 2 diabetes also can be a family history of diabetes as well. Does that clear it up? It was in a table form, and I was asked to select which one is more of genetics, and it was type 2. I'm not sure. I would have to look at the exact question and see exactly what it was asking to talk more on that. It's really hard to clarify questions when I don't know exactly what it was asking. So a type 1 who has blood glucose of 60 less, what is the priority intervention? So a type 1 with a blood glucose level of less than 60, what is the priority intervention? Depends on how symptomatic they are, but they need to get some sugar in their body if they're less than 60. If they're awake and talking, we can give them some juice or some glucose. If they're unconscious, it depends on what range of 60. If they're 12, they will have to, if their blood glucose is 12, they're probably not awake, and they're going to need that IV or that nasal glucose. I will get you the question number. I would need to know what test it was in as well, because the question, just the question number is not going to help. I need to know what test it is in. You can give them some simple carbs, candy. Yeah, absolutely. If they're awake. So the priority is going to kind of change depending on what the range is and how symptomatic the patient is as well. Does that make sense? Okay. Everybody good? Okay. So your first line oral anti-diabetic agents are going to be your sulfonylureas. The use of it is for type 2 diabetes. Your type 1 diabetics are never started on anti-diabetic agents. They are strictly on insulin because their body, the pancreas, is not making insulin, and they need that insulin replacement. We said that your sulfonylureas, particularly your metformin, is used to treat polycystic ovarian syndrome. And the onset of these medications is 2 hours, and they peak in 2 to 3 hours. The duration of these medications is 4 to 9 hours. And it's really important when we're talking about both oral anti-diabetic agents, pills, and when we're talking about insulin, to understand the peak, onset, and duration of these medications. Number one, dosing is they are dosed according to their peak and duration. And also, when do we need to go back and check this patient for signs of hypoglycemia? Metformin does not cause the blood glucose to drop dramatically, and they don't need to be fed right away. And it does take about 2 hours. But these patients do need to eat. You know, when we give them regular insulin, we have to go check them and make sure they have food within 30 minutes because of the onset. But metformin, they don't. Some patients do complain and say that they start to feel a little shaky and weak if they don't eat about 2 to 3 hours after the medication, and that kind of makes sense. It's not going to necessarily drop their blood sugar, but they need something to keep their body going, and that's the peak time of it. With your metformin, they'll start at 500 and they can go up as high as 2,000 milligrams per day. So that might be 1,000 milligrams in the morning and 1,000 milligrams at night. Some of the common side effects of metformin, which we get into adherence with that, is it can cause diarrhea. And then if they're started on 500 milligrams and they're plugging along and a couple months later they're put on 1,000 milligrams, they can have that reoccurring diarrhea as well. So it's a compliance issue and educating the patient that that's a common side effect, not to get too concerned, but to increase their fluid intake. Sometimes patients have complained of some GI upset, loss of strength or energy, and sometimes that has to do with their blood glucose and the changes in the blood glucose level. So they should be still monitoring their blood glucose, especially if they're feeling low energy. Take their blood sugar and see how low it is. They may need dosages adjusted. Can lead to lactic acidosis and then low blood glucose with your glipizide. So, one of the things to know about glipizide is the half life of that is about 2 to 5 hours. I bring up and I mention glipizide because a lot of times people don't really think about that. And glipizide is typically dosed twice a day. I had a patient and also I'll tell you about the patient in a minute, but think about, when does our blood glucose level drop? For anybody who, even if we don't have diabetes, when does our blood glucose drop?
Nighttime.
Nighttime, when we're sleeping, right? So I had this cute little 80-something-year-old lady. She was all of about 110 pounds soaking wet. And she came into the emergency room. I came in at 9 o'clock that morning, and she had been there since right around change of shift at 7 a.m. And her blood glucose was low. And she was hard to wake up. So the family called the EMS. Turned out her blood glucose was 40. They gave her the IV glucose. It came up, but then when we were rechecking it all morning, we were playing with her blood glucose going up and down. We wound up, she ate like probably 5 sandwiches before 11 o'clock. And I went to the doctor. I'm like, why, like, what's going on with this lady? Is there something else going on? And then we realized the family had realized she takes glipizide twice a day, and she had taken her glipizide at 6 o'clock like she normally does. They went out to dinner, and she didn't remember that she took it again or that she had taken it. So she took it again when they came home about 11:30. So now she double dosed it. And remember, your blood glucose normally drops in the middle of the night. So that's why she woke up. But that glipizide, the one she took at 11:30 at night, was still in her system, and it was a double dose. So it really dropped her blood glucose. So she did wind up getting admitted, but because it has a little bit of a longer half-life, we really need to instruct patients on when they're taking it and to take it about the same time and definitely not double dose it. Because and then you think about it, she was only 110 pounds, so she was already a tiny framed woman. The other thing about your metformin is we definitely, if patients are going for a CAT scan with the CAT scan dye, we need to tell them to stop taking their metformin for 24 hours beforehand and 24 hours after, because it can cause lactic acidosis and possible renal failure, because we already know that IV contrast can cause renal failure as well, or can damage the kidneys. So we definitely, you got two that can damage the kidneys. So you definitely want to educate these patients. I did a slide there on your glipizide. The peak is in about 1 to 2 hours, and the duration of it could be 12 to 24 hours. So when that patient took it at 11 o'clock at night, it was still in her system at 11 o'clock in the morning. So because her blood sugar kept going up and down and she double dosed herself, she was admitted to watch and make sure it was excreted. She was 80 something years old. She already had decreased kidney function, so it wasn't being excreted as normally as it would have, and then being double dosed. Some of the side effects you see are a lot of CNS side effects that also go along with your hypoglycemia. So we really need to be checking blood glucose levels on these patients. There are no real food or drug interactions I'm sorry, food or drink interactions with glipizide, but there are some drug interactions, especially your antifungals, the fluconazole. The over-the-counter meds, think about that with your patients too, because a lot of them contain sugar. So we're kind of, if they're taking cough syrup, that's one of the big ones that contains a lot of sugar. And some of your vitamins, especially those gummy vitamins, they can contain a lot of sugar. And now they have gummies or chewables for any supplement that you want. And a lot of times patients are taking those supplements. So a lot of education with that. Any questions on these two meds? We're good. All right. So I put some slides in here on hypoglycemia. Oh geez, I put 770 on there. I thought I corrected that. That's less than 70, y'all. I need to fix that. Less than 70 is a low blood glucose now. Some of the causes, again, they take too much insulin, too much anti-diabetic medicines. They're not eating enough food in relation to what they're taking. And then those patients that become dehydrated or have that severe nausea, vomiting, and diarrhea. Sometimes alcohol can cause hypoglycemia as well as hyperglycemia, depending on what type of alcohol they're drinking. Because remember, a lot of your alcohol can contain a lot of glucose as well. I was going to fix that slide, so I take that out of there. Strenuous exercise can also drop their blood glucose, right? So we might tell these patients to wait a little while and check their blood glucose before and after they exercise if they're doing some strenuous exercise, or if they're out in the heat. We see that a lot with some of our athletes. In the summertime, we get a lot of patients, not a lot, but we tend to see some of our football players that have diabetes, and they wind up out there in the heat in the summer. They're already they've taken their insulin, they've bulked up, they've drank, and then they're out in the heat and they've done a lot of exercise and their blood glucose drops, and they wind up coming into the ER hypoglycemic. Childbirth can also cause hypoglycemia. And some of the signs and symptoms, remember, if it's hypo, everything's going to be lowered. So they're going to start to feel tired. They're going to feel weak. They're going to feel hungry. They can be shaky, and they can get a headache from it as well. And the opposite, your hyperglycemia, anything greater than 125 milligrams per deciliter. Some causes: stress. Just being stressed can raise your blood glucose, along with your blood pressure and your heart rate and everything else, right? Illnesses can cause hyperglycemia. Eating too much carbs or sugars can cause hyperglycemia. Eating a lot of fatty foods and those simple carbohydrates. And then sometimes administering the incorrect insulin dose. I just learned something yesterday that I'm really kind of still in awe about. Some of our facilities here in Georgia are not making nurses do the double checks, 2RN checks of insulin. So when I started looking at the literature, why? Because that's always been an issue and a policy. I could not find anything that has changed that. JACO, which is the Joint Commission of Accreditation for Hospitals, still recommends and still has insulin on their high risk medication. So I'm kind of like, ooh, I don't know about that one. Has anybody seen that, or do you see that in your facilities anywhere? Or is insulin still a 2RN check?
We still have two RNs check.
And in what area are you in?
I am in Dallas with VA.
Okay. Yeah, I still think they need 2 RNs. And you work for the VA?
Yes, I do.
Yeah, good. So that's what I was thinking. And I know the VA hospital here, because one of my students does work there. Right now it's the LPN students. Both meds, metformin and glipizide, taken just before meals. Yes. But with the metformin, you don't have to take it before the meals. Sometimes patients take it after because it can cause some GI upset. Repeat on glipizide. What do you need repeated? I'm sorry. Or what part of it? Jeremiah, I see you put repeat on glipizide. What are you needing repeated?
Elizabeth, you cannot take it for before meal, right?
You can. What do you mean you cannot take it before meals?
Sorry, I mean metformin. You cannot take it without meal, before meal.
No, you
And
can. There's no indication. There's no real like recommendations of it, taking it before or after, but metformin can upset your stomach, so you can take it with, right after you've eaten.
You mean empty stomach? You can take empty stomach?
There's no real recommendation on either or. So, some medications you have to take on an empty stomach, some you have to take with food. There are no recommendations that I'm aware of on either of those medications.
but which one we can hold it when the patient has a surgery?
The metformin. The
Okay, but
metformin,
glizipase we cannot, right?
not with surgery. The metformin needs to be withheld if they're going for a CAT scan and they're using dye. The contrast dye. If they're going for a CAT scan, not for surgery, that would
Is it
be
with
up
surgery?
to the surgeon. That would be up to their pre-op when they go for their pre-op appointment, whether they're going to stop medications or take medications. But before they're going for a CAT scan, the metformin should be held.
Is it within 24 hours? Please?
Yes.
Okay, thank you.
Yes, the metformin is contraindicated if there is contrast dye. So they should not take it 24 hours before or 24 hours after. But again, you know, if we have to do a CT contrast with the dye, with the contrast dye in an emergency, that's when they do more checking of their renal function and make sure. We check renal function anyway before they go for a CAT scan with dye, because the CAT scan dye itself, the contrast, can lead to renal failure. So if a patient has an elevated BUN and creatinine, they may not do it with dye, with the contrast.
Professor, did you say that we should hold metformin for 24 hours before and 24 hours after? I thought it's 48 hours after.
From what I know, it's 24 hours after contrast, and the patients need to increase fluids. I would have to double check if it's 48 hours. I've always...
Yeah, I saw the question on Asha. So they said it's 48 hours after.
Let me look real quick on my other computer.
But the first said it say 48 hours.
Okay. Well, I'm looking here at one study that says there's no need to hold it anymore. So there might be, if your textbook says 48 hours, and then go with 48 hours.
Yes, the textbook said 48 hours.
48
after.
hours. Okay.
Yes.
And I will change that. I made a note of it.
It's 24 hours before and 48 hours after.
So here's a study in PubMed, which is the National Library of Medicine, on metformin, and it says from a Canadian association, as long as their glomerular filtration rate is less than 60 milliliters per minute, they don't even need to hold it. Stopping metformin before restarting. Yeah, so this is saying restarting depends on the renal function and the volume of the contrast used. So I guess there seems to be a little bit of a controversy, but I would go with what your textbook says then. And if your literature says 48 hours, yes, to minimize, and that's what it is. It's going to minimize the risk of renal function, acute kidney injury as well. So I will change that on my slides. And it's not necessarily 48 hours before. It's the day of, if they can, and after, because they haven't had it. 48 hours before, hold 48 hours before, okay? Most literature, so I'm gonna have to really look at that more. Ferdinand, do you have anything to add on that? All right, I will look at that and change my information then. I'll do a little more research on that. So insulin is going to promote that cellular reuptake of the glucose in the cells to lower the glucose levels. We use it for DKA patients, diabetic ketoacidosis, and hyperglycemia. Some of the side effects are hypoglycemia, hypokalemia. That is why we often give potassium, either PO or an IV piggyback with our insulin if they're extremely high glucose levels, especially our DKA patients. Lipohypertrophy is those little bumps that patients get under their skin. They're subcutaneous little fat tissue that tends to develop if they're administering the subcutaneous shots in the same area. Can cause some nausea and vomiting as well. There are some interactions with our medications. Thiazide diuretics and glucocorticosteroids can increase the blood glucose. So anytime a patient is getting Ciamedrol or prednisone or glucocorticosteroids, we definitely need to be monitoring blood glucose levels, even if they are only type 1 or type 2 diabetics. Sometimes those patients that come into the hospital, they're getting corticosteroids, their body is stressed, their blood glucose levels go up, and they need to be covered with that insulin. So oftentimes we're educating these patients when you go to give them insulin, they're telling you, I don't take insulin at home. I'm a type 2 diabetic, and we have to do some education as to why they are now getting insulin. And most often it's short term, unless there's something that's causing that blood glucose to stay elevated. Sometimes pancreatic tumors, pancreatic cancer, liver disease might make a patient require insulin that never had it before and only type 2 diabetic. Your beta blockers and alcohol can cause hypoglycemic effects. The alcohol, because these patients can become dehydrated, it can also cause hyperglycemia, like I said earlier, depending on the type of the type of alcohol or what they're drinking. Definitely nursing interventions, we want to rotate their sites, double check dosage with another RN, ensure that they have had food within 30 minutes of the regular insulin administration, and that's because the onset of action is 15 to 30 minutes. If you're mixing insulin, remember it's clear to cloudy. Some facilities, a lot of facilities have gone to the Novolin and the Humulog 70/30, where they get 70% of that NPH long acting and 30% of the regular, which is the short acting and immediate acting. So, but there are some facilities, a lot of the nursing homes, some of our VA facilities are still mixing the insulin, and I'll show you how that gets done in just a few minutes. Definitely want to keep the vials refrigerated after opening. We see a lot of insulin out in the med rooms, in some of the floors. Make sure it gets put back in the refrigerator. Some facilities are now going to, if this patient is on insulin, they get their own bottle and not a multi-dose vial anymore. we use insulin syringes to administer insulin, only insulin syringes, and those are measured in units. And then we definitely want to get their blood glucose level prior to administration. We don't want to use a blood glucose level from 2 hours ago. A lot of our facilities here, the techs on night shift will go around and do those blood glucose checks before the day shift gets here. And then when the nurse is now administering insulin at 7:30, 8:30 in the morning, they're using those previous blood glucose levels. That's not accurate because we know that can change at any moment. And then educate those patients who are on insulin to wake themselves up or have a family member wake them up and test their blood glucose at least once a week in the middle of the night to make sure that they are not dropping too low. We also need to monitor that hemoglobin A1C to see what the 3 month prior to the trend of what their blood sugars are running. Any questions? Yes, there's agreement from both of faculty for Naxlex that they've often heard of 24 hours before and 48 hours after. So it's something we're going to have to research a little more. Like I said, doing a quick look, there are literature that says as long as their renal function is okay, they don't have to just make sure they're drinking lots of fluids. Thank you. So I put in here a table on the insulin, your rapid acting. See, the onset is 15 to 30 minutes and the duration is 3 to 6 hours, which is typically why we're doing blood glucose checks every AC and HS because of that duration. And they peak, which means that's when they're working the best and now they're going on the downslide at 30 minutes to 2.5 hours. So again, that's how we are measuring those blood sugars, AC and HS. The short acting is 30 minutes to an hour, and you see they peak in an hour to 5 hours. And then your intermediate acting onset is 1 to 2 hours with a peak of 16 to 14 hours. And it can stay in your system for 24 hours. So those are your NPH or your levomirs because they last a little longer. And then your long acting are going to have an onset of 70 minutes and a duration of 18 to 24 hours. So again, even longer. And that's your glargine insulin. So steps to draw up insulin, because I do know there are questions on Naxlex about this. Remember, you have to place the air in the vials of glass, both of them, before you withdraw. And the reason you do that is so that you don't get air bubbles in the syringe. You're going to inject the air into the NPH vial first, and then inject the air into the regular vial because we pull up the regular insulin first. So you already have the needle in there, you're pulling it, or the needleless needle in there, so you're pulling up the regular and then you're going to the NPH. So this is where you really have to be very accurate and be able to draw up that insulin so that you're not getting air bubbles and that you're getting the correct amount, because you don't want to push that mixed insulin back into either vial if it's not a correct dose.
Professor,
Yes.
come up again on insulin types.
I can't, I'm not hearing you very well. There's a lot of background noise. What?
The last slide.
Yes. What about it?
I want you to repeat it again. Yes, that
Oh,
slide.
okay.
Thank you.
So these slides are posted on the site. Are you good? Can I go on, or you still need it?
You can go on.
Okay. So there's your insulin syringe. Remember, an insulin syringe only draws up insulin, and we only draw up insulin in an insulin syringe. They are measured in units. They typically, here in every facility I've ever been in, worked in, taken students to, they are those orange caps. So there are some other insulin delivery devices. Obviously, your insulin syringe, some patients have the insulin pen. Your Levemir is going to come in your insulin pen. Your GLP-1s are going to come in your jet injector, and then an insulin pump. So your insulin pumps are set at a steady dose that is being delivered continuously to these patients, and they wear the insulin pump. The new standards, or the new standard of care and practice, is that if they have an insulin pump on, that they need to also, or in use, they also need to have the 24-hour continuous glucose monitoring devices as well. And I'll show you that next. So you see the pump is there on the screen. It's on the right side, and the glucose continuous monitoring device is on the left side. Most often those devices hook to or read out on the smartphones. So in order for the patients to get an insulin pump, they must be able to demonstrate the ability to adhere to those multiple daily injection regimens to begin with. The physicians and the staff need to know that they're going to be compliant, because that is giving them insulin constantly. So strict monitoring of that blood glucose. They must go through training and meet with the diabetic educators in most facilities, and then be able to operate the pump itself. And then also counting those carbohydrate intake, because those insulin dosages are often adjusted according to the carbohydrate intake. And then be able to change the infusion sets and troubleshoot. Most of them are going to provide a variable rate, which we call the basal rate, but it's going to be varied from patient to patient depending on what their blood glucoses are running. That amount of insulin is comparison to what they're eating. So that may also change. Some of the pumps will change the amount of insulin according to those blood glucoses. So nursing care, most often when patients come into the acute care facility with insulin pumps, they are asked to turn them off or, disable them so that we have better care or better adherence to it. Check your facility's policies as to what they require. Settings are your basal rate compared to the carbohydrate ratio, and then their insulin sensitivity factor, and then what is their target blood glucose. And again, that possibly could be different for every patient depending on where they are, because it's so individualized. As far as nursing wise, we need to assess and document the presence and the location of the pump. It would be really good to get the pump manufacturer and model. Sometimes if those patients are allowed to keep them on, you do need a physician order, And then if you need troubleshooting, you need to know who to call or what to do with it. What's the type of insulin? Where's the insertion site? And what are the settings? And then continual monitoring of that glucose insertion site.
Professor, can you repeat this again? The basal rate is for what?
For the insulin pump, it's a steady rate of insulin. It's going to probably be a very small dose. And I couldn't even tell you where it starts because, again, it's individual, and they give a basal rate. So they get a continuous stream of insulin through that insulin pump according to what their blood glucose is. See this monitor right here? That's a blood glucose monitor. So that's continuous. It'll take readings continuously. And see how your pump, it says 5.1. I'm not real sure how that's measured because, again, it depends on the person and the pump.
Okay,
A lot of
thank you.
times the insulin pumps are a lot smaller than that now.
Thank you.
So does anybody have any questions on your NAXLEX page? Go to previous webinar. Oh, okay. Okay. Any questions? All right, so let's do a couple of questions on insulin. A client becomes restless 15 minutes after receiving a dose of Lispro insulin. What is the nurse's priority action? So that's a priority question. So it wants to know what's the first thing you're going to do?
Check the blood glucose level.
B.
Yep.
Check
Check that blood glucose level, right? Because they could be restless for any number of reasons. It may not be related to blood glucose, right? But we know that the onset of Lispro is pretty quick. So get that blood glucose level. If you had to put those in order, if the question said put them in priority order, we already know B would be first. What would be next?
If it were to be high, stop the next insulin dose, then
Yep.
administer glucagon and then inform the healthcare provider.
Well, you're correct about C. You are going to stop the next insulin dose, but you need to inform the healthcare provider first. Most often they have a PRN order for glucagon, but we're not going to go to that glucagon right away until we know what that insulin reading is, that blood glucose level. So if you're a med-surg nurse and on the floor, you would definitely inform the healthcare provider first, because most often that glucagon is a dose for hypoglycemic. So you probably want to inform them first of what's going on. Does that make sense?
Yes, Professor.
How many days it should be continued? How many days it should be continued? What should be continued? Tripty, I'm trying to answer your question. How many days what should be continued? An insulin pump is continuous. These patients have it continuously. Most often your insulin pumps are, well, not most often, they are. They're for your type 1 diabetics, so they need insulin all the time. Does that help? A nurse is educating a client taking metformin for type 2 diabetes. Which statements should the nurse include in the teaching? So this is a select all that apply question, and you can see that it says select all that apply, but there's also 5 answer choices versus your typical multiple choice have 4 answer choices. So what do y'all think?
ADE.
I think it's AD.
AD, yes. It is A and D. Taking the medication with meals to reduce stomach upset, because we know GI upset, diarrhea, and nausea, vomiting are side effects. And then limit the alcohol intake while taking this medication. Well, they're probably going to be on the medication for life, so that is the correct answer, but they need to limit alcohol intake probably forever. We don't ever want to tell them to double the next dose, because it could drop their blood sugar too low, right? Just like my lady with her glipizide. It doesn't cause weight gain, but it can cause about an 8 to 12 pound weight loss. And then you should stop taking this medication if you experience any diarrhea. No, we need to educate them that diarrhea is a known side effect and they need to continue taking it, but increase their fluid intake and maybe eat a brat diet until their body gets used to that medication, because the diarrhea does subside. A nurse is caring for clients with type 2 diabetes mellitus. Which medication should the nurse prioritize monitoring for hypoglycemic reactions?
A. A.
Yep, A, glipizide. Yep, your linagliptin and your sitagliptin, they work by enhancing and excreting the hormones to increase insulin. And they work after the patient has eaten. So they increase the insulin after a meal. And then the pagliflozin, I can't say some of these words, reduces the blood glucose by promoting urinary glucose excretion. So it's being lost in the urine. But your glipizide is going to cause your most, or it's going to be the priority for monitoring hypoglycemia.
Sorry, Prof. On the previous question about limit alcohol. So Sam is trying to ask, why is it not avoid? Why is it limit?
Well, I'm not sure. I didn't write the question. These come from a lot of your NASLEX test banks, but that's what I was saying. It says limit alcohol intake while taking this medication. I'm more so saying they're taking this medication for life, pretty much. Unless they can totally get their blood glucose under control. And, sometimes with weight loss and strict diet and exercise, patients have been able to come off of their oral anti-diabetic medications. You probably should avoid alcohol, but limit and avoid, it's kind of a semantics on words.
The distractor.
I'm sorry? Education. Yeah, it is part of education. So if you have somebody who's an alcoholic or somebody who drinks alcohol every day and they're now put on metformin, we have to work with our patients. Are they absolutely going to stop it? Are they going to be adherent? But we can educate them to limit it and maybe do an education plan and say, hey, can we mutually agree that you just drink alcohol on the weekend? That's limiting it, right? So we also have to meet our patients where they are, right? Telling
Yes.
somebody to stop smoking if they smoke 2 packs a day is not going to work. We have to wean them down and wean them off of it, right?
Yes, ma'am.
Okay, so the answer remains A and D.
Yes, the answer is A and D. Yes. But when we practice these, the way you all learn and the best way to learn and teach it is to provide the rationale for the incorrect answers as well, so that you can see why is it correct and why is it incorrect.
Yeah.
So it's Sam, it's A and D. Yes. Okay. A nurse is teaching a client about proper administration of regular insulin. Which statements by the client indicate an understanding? So again, this is a select all that apply question.
C and E.
C and E as an elephant?
Yes.
Yes. C and E as in elephant are correct. You want to draw up the regular insulin first if mixing it with NPH insulin in the same syringe, and you definitely want to rotate injection sites to prevent tissue damage. We don't ever, when we're talking about regular insulin, it should never be cloudy. So it's not correct to say that they can use it even if it's cloudy. NPH insulin, however, can be cloudy and typically is a little cloudy looking. You want to tell them not to inject regular insulin immediately after eating. They need to eat it. They need to inject it before eating and then eat. And then we never store insulin in the freezer. It goes in the refrigerator. Clients with type 2 diabetes mellitus are scheduled for a CT scan with contrast dye. Which medication should the nurse instruct the client
B.
to withhold prior to?
B.
B, metformin.
Yep. I think we beat that one, right? That one we beat to a dead horse, right? We talked about that one a lot. So it is B. We don't have to withhold the insulin, and we don't have to withhold the lisinopril or the atorvastatin. What is the classification of lisinopril?
That's for cholesterol, right?
ACE inhibitor.
The
AC.
lisinopril is an ACE inhibitor. Atorvastatin is for cholesterol. It's one of your statin medications. And then insulin glargine is your long-acting insulin. So let's talk about the thyroid a little. What is it? It is part of the endocrine system, and it is an endocrine gland. It's going to release some hormones, which their main role is to control metabolism. So that's why when we talk about hypo and hyperthyroidism, it has to do with metabolism. It's either an underactive metabolism or an overactive metabolism. So when we talk about metabolism, we know that it's how the body uses energy. Where is it located? It is in the front of the neck, and it is a small butterfly-shaped gland, but it can cause a lot of problems in patients. Most people get enough iodine from their foods and the iodized salt and water that we drink. And that is a thyroid. It does need iodine to make those hormones. It does make and secrete the thyroxine, the T4, and the thyroidine, which is your T3, and then your RT3 and the calcitonin. So patients who have thyroid disease sometimes can have some really serious symptoms that present a lot different. My second niece, and how this happened was just really weird. It was probably, oh gosh, it was at least 10 or 11 years ago. She was kayaking and got injured her shoulder. But later that night, she started having some, more so some changes in level of consciousness and just acting kind of strange. So, we thought maybe she hit her head when she overturned the kayak and injured her shoulder. So she went to the ER, wound up getting a CAT scan. Everything was fine. Nothing showed up on the CAT scan. She went home, and over a course of about a week, seeing her primary doctor, seeing the orthopedic for the shoulder injury, and all of that, she wound up then developing these weird spasms with her muscles. She became very confused, very confused. When she was young, my sister brought her back to the ER, and we thought, I mean, she doesn't use any illicit drugs or anything that we knew of. But of course, we were like, test her for that. How old was she? She was probably mid-20s at that time. So like 22, 24, we were like, she's not the type that could use illicit drugs, but she was acting like possibly she could have been. They did drug screens, they did everything, re-CAT scanned her head. She was also having symptoms that I wasn't sure if she was having stroke symptoms because her speech was really slurred. So after about 10 days, doctor's visits, ER visits, they wound up then thinking maybe it was a psychosocial mental breakdown and was just exhibiting itself really weird. And which, of course I didn't want them to go down that road, but we were desperate to try and figure out what was wrong. It wound up being her thyroid. And one doctor in the ER, I happened to be working in the ER and was talking. My sister worked at the hospital too. And I happened to be talking to the ER doctor. And I'm like, look, can you guide me? Can you tell me what to tell my sister? And she wound up saying, check her thyroid. And she wound up having emergency partial thyroidectomy, and she's been fine ever since. She has to take thyroid medicine, but it was her thyroid. She was hypoactive, and all of her symptoms were from that hypoactive thyroid. So it is an important gland in the endocrine system that does control your metabolism. And I'm like, wow, that is, I'd never seen that in my 30-something year career. So just kind of think of those outside of the box things when patients come in with some weird things. I like to give you all examples of patients I might have seen or I know that have had some weird things so that you just it kind of just brings it all together. I hope it's helpful for you. Please, can anyone help with the sharing of today's recording? It's not going to share until we're done, and it's going to be in previous recordings. So the function of the thyroid is for heart rate, metabolism, breathing, helps with temperature regulation, and then brain development as well. Mental activity, and then skin and bone maintenance. And then it can also cause fertility and infertility problems as well. It will help regulate the amount of blood that's pumped through the heart. And then a malfunctioning thyroid gland can affect the nervous system, and it can cause numbness, tingling, and depression and anxiety. So for my niece, it wound up causing a lot of nervous system issues and also musculoskeletal with her walking. So, and being able to move. So, some factors that affect the thyroid: stress, infection, trauma, some medications, toxins, and then autoimmune disorders are gonna inhibit the production of the thyroid hormone. So these patients are gonna tend to be hypothyroid. Factors that can increase it: too much zinc, too much selenium. Sometimes patients are taking selenium for brain function. And then zinc, a lot of times patients will use zinc to boost their immune system. Factors that increase thyroid: your stress, trauma, we know for sure, low carbohydrate diets. A lot of those patients that put themselves into ketosis can wind up having some thyroid issues, and then liver and kidney dysfunctions. So hypothyroidism is obviously that underactive thyroid function where the thyroid itself is not making enough hormones, so it requires replacement from medications. And the first line and most often prescribed is your levothyroxine. Over time, if hypothyroidism isn't treated, it can lead to a lot of other health problems. These patients can develop cholesterol problems and also heart problems. So your levothyroxine is a synthetic form of hormone, obviously, because it's a medication, right? It's going to increase the metabolic rate, protein synthesis, and the cardiac output, as well as renal perfusion, oxygen use, body temperature, blood volume, and growth processes. So look at all the things that levothyroxine does. And if you go back and look at this, your functions of your thyroid, it's one of those medications, and that's why they use it, that hits every one of the functions that are all going to be misfunctioning or malfunctioning in patients who have hypothyroidism. We also use it in myxedema coma, and we definitely needs to use it when we're maintaining the thyroid levels after surgery or radiation on that thyroid if these patients have had thyroid cancer. And unfortunately, they can get thyroid cancer, and it is a pretty common cancer as well. Contraindications of use are with pregnancy, adrenal insufficiency, and patients with diabetes, they definitely need to be using it with caution, and also monitoring their blood glucose levels, because remember, diabetes is a metabolism disorder as well as thyroid disorders. So some side effects: excessive swelling, insomnia, increased heart rate, increased appetite, because if we're using it to treat hypo, it's going to do the opposite. It's going to make everything greater, right?
Professor, please, can you go back to functions of thyroid again? That one. So, yeah, I don't know that it affects growth and development too.
What do you mean?
Yeah, I
Say
saw the growth and development.
right. So especially skin and maintenance, because kids can develop thyroid disorders as well, especially in their teen years. But if
Oh,
they're on levothyroxine, it's going to help with that growth process.
okay, thank you.
Mm-hmm.
Excuse me.
Yes.
Yeah. Tyrosine will alter blood glucose level. I guess it's gonna cause hypoglycemia or hyper.
It's going to cause hyperglycemia because remember, it increases everything. We take it for a decreased metabolism, and if we're giving the medication, it's going to increase the metabolism.
Yeah. Okay. Thank you.
So some of our nursing interventions, we want to obtain baseline vital signs, definitely get a baseline weight, height, assess their cardiac status, get a baseline EKG, and then monitor those T4 and TSH levels. This is one of those medications that works well on an empty stomach, and it is lifelong therapy. The medications need to be taken with a full glass of water, because that helps with absorption of it, and also sometimes the timing of it. Sometimes patients will wake up at 3, 4 in the morning and take their thyroid medication because they find that's when it works the best. Because again, remember, when we're sleeping, everything slows down. They do use levothyroxine, the IV form, with myxedema coma, which is a rare complication of, and it can be a life-threatening complication of hypothyroidism, where these patients develop multiple organ abnormalities, some altered level of consciousness, and it can occur very quickly. Our corticosteroids also affect our endocrine system. Their corticosteroids are released. Again, they are natural hormones or substances that are released in the body. They are released by the adrenal cortex, and they help to decrease inflammation. So we use them for inflammation in the body. We use them for respiratory issues because remember, that's an inflammation in the bronchial airways. We use it for a lot of autoimmune disorders, allergic reactions, anaphylaxis, sometimes arthritis, because again, arthritis is an inflammation. So is eczema. So any disease process that causes inflammation in the body, corticosteroids can be used. We also use it for migraine headaches in the form of Decadron, and for sometimes some head injuries, to decrease the swelling. PO is your prednisone. The topical is cortisone, and then your IV or PO is also hydrocortisone, and then your methylprednisolone, your Solumedrol, is IV, and we use that a lot with asthma attacks, COPD, anaphylaxis, and some of your autoimmune disorders. Side effects, especially with your POs, is GI upset. These patients tend to get an increased appetite, develop sodium and water retention, can have some muscle weakness, and mood swings to the extent that they can have some psychosis with corticosteroids. Can lead to anxiety, increased blood glucose levels, we all know that, and hypertension. So your IV form, you want to administer slowly. Definitely monitor blood glucoses. Good skin assessment because it can cause bruising and it can also thin the skin if they're taking long-term corticosteroid therapy. And then administer with food to decrease that GI upset. Any questions?
Professor,
Yes.
is one of the side effects says increase appetite.
Yes.
So does it mean that weight gain can be a side effect also?
Yes, it can be. But weight gain can also be because of the sodium and water retention.
All right, thank you.
If patients are on prednisone, they have a ravenous appetite.
Professor, my
Yes.
question would be liver thyroidism. So does it synthesize with T4, T3? Because
Does it do what?
synthesize with T4.
I believe it's with T4 because you definitely need to be monitoring the T4 and the TSH.
Okay, thank you.
Any other questions? All right, let's do some questions. A nurse is providing instructions to a client with hypothyroidism about taking levothyroxine. When should the client take this medication?
B.
B, yep. This is one of those medications that's best taken on an empty stomach or in the middle of the night, early morning if they can wake up. There's no real rationale for the other answers because they're all wrong, right? So we don't need to go through them. A nurse is educating a client about mixing NPH and regular insulins. Which of the following statements indicate proper understanding? Which ones? Yes, A and D. I should inject air into the cloudy insulin bottle first. Remember the slide I showed? The air goes into the cloudy one first and then the clear. I should draw up the clear insulin first, yes, and then the cloudy. And we never want to shake the insulin vials. We don't need to roll. We roll them. We put them between our hands and we roll it. You never want to shake them. And we don't need to roll the regular because it's not cloudy, right? We just definitely need to roll the NPH. A nurse is caring for 4 assigned clients. Which one should the nurse assess first? So this is a priority. Which one is the most serious?
D.
Which one?
Professor D.
D.
D?
D.
Yes.
Yeah.
D as in dog. Yes. And so most of the time I like to ask you guys to rank them, but the rest of them, there is one that you should see next. Which one would you see next?
C.
C. Yeah, because she can go into that mixed edema coma, right? So the other two, both of those, they're experiencing side effects. So I may go see the metformin patient first because maybe if she has a PRN order for nausea, I'm sorry, a PRN order for ondansetron, I can administer it. But your patient with the prednisone, they may have ankle swelling, right? So that's not going to kill them right now, right? But that 48 blood glucose, that patient could become very sick, right? A nurse caring for several assigned clients. Which of the following client requires the nurse's immediate attention? So again, which one are you going to go see first?
B.
B, yep. They're feeling shaky. That's one of the first signs of hypothyroidism. And we know with NPH, what's our peak and onset, right? The one I would probably see next is that client that was initiated on metformin for the first time, to make sure that they're not having any adverse effects. And then probably the patient on glipizide reporting the headache. Why do they have a headache? And then the type 1 diabetic who is scheduled for a meal in 30 minutes. That's kind of one of those do nothing answer choices. You know, it's not saying that anything's wrong with that patient. And we know if they're on metformin, they don't need to eat right away, right? And we know if they're on glipizide, that's going to take a little longer to work. So 30 minutes, they're good, right? Does that make sense?
Yes, Professor.
A nurse is caring for a client on prednisone. Which of the following adverse effects should the nurse monitor for?
B.
C.
C, yep. Long-term prednisone can cause bone loss. These patients can develop bone loss with the corticosteroids. Your corticosteroids are going to increase your heart rate, increase your blood glucose, and increase and could cause hypertension, not hypotension. A nurse is teaching a student nurse about insulin therapy. Which of the following has the fastest onset of action?
C.
C. What's the onset of action?
15
to 30 minutes.
15 to 30 minutes.
15 to 30 minutes. Yep. What is the next fastest onset of action?
B.
Regular insulin.
Regular insulin. And what's that?
30 to 1 hour.
30 to 60 minutes. Yep. And then which one is next?
NPH insulin.
NPH. NPH is about 2 hours. And then what is your glargine?
24 hours.
3 to 4 hours. Yep. Good job. A nurse is educating a client on levothyroxine for hypothyroidism. Which of the following should be included in the teaching?
C.
B, yep. Take on an empty stomach. We don't ever want them to double the dose. We don't want them to take it at bedtime, and we don't want them to take it with food, right? A nurse is educating a client on metformin for type 2 diabetes. Which of the following statements indicate proper understanding?
Yes, C.
I think B.
Yes, it's B.
Oh,
It is B. Metformin helps lower that blood sugar levels without causing insulin spikes. And we do give it with food. Remember, they can take it with or without food, but it can upset their stomach, so they can take it with food. It does decrease those GI side effects, and it enhances the absorption of it. It does not cause weight gain, but it does cause about an 8 to 12 pound weight loss. It does not cause insulin spikes, and I will take it only if my blood glucose goes above 200 is incorrect, because we don't want the blood glucose to go above 200, right? We want them to take it every day to keep it lower or more normal. A nurse is teaching a diabetic client on identifying signs of hypoglycemia. Which of the following should the nurse report?
C.
A.
Okay.
ACD.
It's a select.
ACD.
Yeah.
A, C, and D.
Okay, so the answers are actually A and C. These patients can become very diaphoretic. They typically have tachycardia
Of course.
because, I'm sorry?
Sorry, I'm just confirming what you're saying.
Oh, okay. They typically have tachycardia because their heart and their body is trying to compensate for that low blood glucose. They tend to get confused. They don't get skin flushing. They tend to get pale because they're about ready to pass out. And they don't have increased urine, they have decreased. Your increased urine, your polyuria, is seen with hyperglycemia. Everybody see that? A nurse is educating a client prescribed prednisone for ulcerative colitis. Which of the following instructions should the nurse include?
C.
It's a select all that applies, so it's more than one answer choice.
A and
Is A, B?
A, B, C.
So the answer is
And D.
A and C.
A and C. Yes.
Yeah.
Report any sore throat to the healthcare provider, because remember, prednisone also can increase the white blood cell count, and your corticosteroids. So a sore throat is a sign or symptom that they could be developing an infection. Then also take with food to decrease the GI upset. Remember, swelling of the legs and fluid and sodium retention are side effects. So
Yeah.
we're not going to tell them to stop the medication. We're going to then provide some nursing interventions to alleviate that swelling. What could be some nursing interventions we would tell them to do? For leg swelling, what would we tell them to do?
Elevate the leg.
Elevate the legs, wear compression socks.
Yeah.
They don't have mild weight loss, they tend to have weight gain. And limit the banana intake while on this medication is not correct, because prednisone can cause fluid retentions as well, and we want to get the sodium removed from the body. We actually want them to eat bananas because of that fluid loss, to keep their potassium up because of that sodium loss. A nurse is teaching a client initiated on NPH and regular insulin therapy. Which of the following statements indicate proper understanding? And that is a select all that apply.
A and D.
A and D, yep. We kind of talked about these. You don't ever shake the bottles. You roll the NPH insulin. They don't take it at bedtime only, right? They may get it twice a day dosing. And you don't want to inject air into the regular vial first. A nurse is educating a student nurse on glipizide use in diabetes mellitus. The student asks how the medication works. Which of the following is the best response?
I think B.
Yep. Yep. It stimulates the pancreas to release more insulin, right? Because patients who are on oral anti-diabetics, they make some insulin, but not enough, right? A nurse is caring for a client who has been newly initiated on metformin therapy. Which of the following is a priority nursing assessment for the client? So remember where we said metformin was excreted?
C.
Or how it's C.
C, kidneys.
Yep, the creatinine level through the renal system, right? A nurse is caring for a client taking levothyroxine for hypothyroidism. Which of the following findings indicates an overdose of the medication? So remember, levothyroxine increases.
C.
Well, it's a select all that apply.
C and B.
C
So-
and E.
So it's actually A and C. So patients with hypothyroidism tend to have cold intolerance. So if we're giving them a medication to combat their symptoms of low thyroid, they can have heat intolerance. So their body temperature can raise. And then tachycardia because it increases the heart rate. Constipation slows down, right? That's the body's, the bowels, the guts not working. Cold skin is a symptom of hypothyroidism, and hypersomnolence means that they're very sleepy. Does that make sense? We watch for signs of hyperthyroidism. Yep, that is true. A client with type 1 diabetes mellitus receives NPH insulin subcutaneously at 7 a.m. At 1500, 3 p.m., the client reports feeling shaky and dizzy. Which of the following actions should the nurse take?
C, check the client's blood glucose level.
Yep, because we know NPH peaks how long after?
6 hours.
4 to 12 hours. A nurse is caring for a type 2 diabetes mellitus client who asks when to take glargine insulin. Which of the following is the nurse's best response?
C, once daily at the same time.
Yep, that is correct. Remember, that's a long-acting insulin, so it's often dosed once a day. A client is prescribed levothyroxine for hypothyroidism. Which of the following statements by the client indicates a need for further teaching? So we're looking for an incorrect statement by the patient because it's indicating a need.
It's A. A, because it should be taken before breakfast.
Yep, that is correct. The
Empty
answer choice is
stomach.
A. Yep, on an empty stomach. A nurse is assessing a client who is taking levothyroxine for hypothyroidism. Which findings would indicate drug overdose?
B.
B, yep. A nurse is monitoring a client with hypothyroidism who is on levothyroxine. Which of the following necessitates immediate reporting to the healthcare provider? So this is a priority question.
Yeah, the heartbeat is so fast.
The heart rate, yep. Yep, we don't want that heart rate to get too fast. So does anybody have any questions on any of this?
Yes.
Just want to download it. If you can send it as the notes, please.
It will be downloaded once the session's over.
Okay, thank you.
So wisdom is not a product of schooling, but of the lifelong attempt to acquire it. So if you give me just a minute, the person that asked about that Cat 8 question 42, I'll see if I can look at it real quick and get back to you. Just give me a second.
They're all good questions.
So I was looking at that question and it does the answer for that one, because it says it has a high genetic predisposition, which means it's genetic, it's type 2, which that is true. It also does say that type 1 with a particular, which now I can't get back to that question. In the rationale, it does say that type 1 diabetes, it is insulin deficiency. Obviously, that's also it. It's early onset, thin body stature, and it's characterized by an absolute deficiency there is a significant genetic association that predisposes one to developing type 2 diabetes, especially if a parent or sibling has the disorder. You're more likely to develop type 2 if your parent has it. Type 1, on the cheat sheet, it does say that under the etiology, that genetic factors such as specific HLA haplotypes increase susceptibility to type 1, but I'm not real sure. I will pass that on and have the NASLAC team look at it, because it does also say that type 1 diabetes is believed to result from a complex interplay of genetic predisposition and environmental triggers. So I can just pass it on for you and have them look at it. Does that sound good? So, I really enjoy your teaching style. Thank you. During IV infusion, can we neutralize by insulin egg dextrose? I'm not real sure what you mean by that. I don't know what insulin egg dextrose is. Good morning, ma'am. You must be across the ocean because it's nighttime at my place. I'm Eastern time and it's after 11 o'clock. But good morning. I am a new student. Please, how I know the next time for lectures. There is a schedule on the NASLEX website that will tell you the schedule for the lectures. Where do we see the download? You're not going to see it until the session has ended. Any other questions? Tripty, I'm not real sure what you're asking me. Can you clarify that so I can try and help you?
When we give IV infusion dextrose, then can we dissolve insulin inside the dextrose to neutralize the dextrose for diabetic patients?
Can you administer insulin through an IV line that it already has dextrose?
Yeah, IV dextrose for neutralize sugar. In dextrose in aqua, we know that they have sugar. So we need to neutralize by insulin. For diabetes patient, give this dextrose in aqua saline.
So if you're not going to give insulin and dextrose. If the patient is hypoglycemic, then they're going to get dextrose, the D50. We have IV that there's sugar like D5 water, right? Yes, there's D5 normal saline, but that's like 5% dextrose. but we're talking about two different things. We're not going to give, I'm not sure what you mean by neutralize insulin with dextrose. If they're on an insulin drip, they're not going to get D5 infusion until they get to their target. So they're going to get normal saline with the insulin drip, the insulin infusion, and normal saline. But then typically the target to get their blood glucose down to is going to be about 80 to 220. And that's once they get there, that's when you give them, you switch over the IV fluids to the D5, and then you're going to check their blood glucose levels and discontinue the insulin drip, the insulin infusion. Is that what you're asking? Because I'm not sure what you mean by neutralize. Is that what you were asking?
I think she's good. She said thank you.
Yeah, I just see that. Yeah. Any other questions?
Professor, when is your next lecture? Is it on the schedule?
My next lecture, yes, it's on the schedule, but let me find my calendar. I'm looking to tell you what it is. My next lecture is on June 5th. It's pediatric pharmacology. And then on June 12th, I'm doing analgesic pharmacology. And then on June 19th, I'm doing respiratory pharmacology. I have other ones in there though too, because I teach two classes. I teach pharmacology and pediatric. On June 3rd, I'm doing a childhood pediatric course.
Okay. Do you know what time on June 3rd? I want to
On what day?
Like what time?
Typically I'm the 9 o'clock slot, 9 p.m. But I do have on what day did you ask me?
June 3rd.
The 3rd I'm at 7, the 5th I'm at 7.
Okay, thank you so much.
And all the rest are 9 o'clock after that.
Okay. Thank you. Have a good night.
You're welcome, you too. Anybody else have any questions? All right. Well, if nobody has any questions, I'm going to say goodnight.
Can you please send us the notes?
They're going to be posted as soon as this is over. How do you join the class? You have to go to the NCLEX website and pick which classes you want and look on that website. It'll tell you how to join.
Okay,
Yeah.
after
night,
class,
Professor.
after class end, where did they send the lecture and I can download it?
Under previous sessions. Yes, that is Eastern time. It'll be
Where
under.
can I see the previous lecture?
It'll be under previous sessions.
In where? NCLEX?
Yes.
Okay, thank you.
You're welcome.
Good night, Professor. It was a great class.
Thank you. As long as you have access to the NASLEX QBank website, all of the lectures are accessible on the menu.
Professor, I have a question.
Sure.
So I've been going over my drugs, like sulfa drugs. I'm wondering which ones are like high yield. I know the insulin, I heard, but it's so many drugs. I'm trying to do all these mnemonics.
Okay.
And do like a chart for each one. But I'm still kind of getting things mixed up.
Learn the drugs by classification.
So like sulfa.
Well, sulfa, there's not a lot of sulfa drugs.
Okay.
There's they use a lot of sulfa drugs for urinary tract infections. The actual sulfonamides are an antibiotic, and those are used for urinary tract infections.
I also seen those sulfonylureas, like glipizide and glyburide.
Those are sulfonylureas, and they don't contain sulfa.
Also, they're not part of the sulfa drugs?
No, they're not. No, those are those are called sulfonylureas.
Okay.
And they're anti-diabetic medications. So basically, like if you go to my huh? I'm going on here. We're coming back here. All right. Sorry, my daughter was telling me she's going somewhere. If you go back and you look at the slide, I gave you all of the information about that classification, and all of the drugs are going to work the same. I did make a point of talking about glipizide because that is the one drug in that classification that has that longer half-life. So I would, like learn the drugs according to the classification, and then those that might stand out or have just a little bit, something a little different, I would definitely make sure I know that drug.
Okay.
I mean, there are so many drugs out there. So, but understanding how those classifications work, I tell students make drug cards or make make them like flashcards. That's what I did when I was in nursing school a million years ago, and we still do that with our students. We still make them make drug cards because it just helps. It's all there. It's on a, condensed area, and put it in your own words.
Right, because I was told that the glipizide in that gives you Steven Johnson syndrome because you have to watch out for hypoglycemia.
Well, hypoglycemia and Steven Johnson syndromes are two different things. Your sulfa drugs and your antibiotics cause Steven Johnson
syndrome.
Let me I've never heard that. Let me I'm looking up I'm going on Lippincott Advisor. Give me just a minute. Okay, so that didn't help me. So there is, okay. So it's a second generation sulfonylurea, which I guess there could be some cross issue with sulfa allergies. There's only one case documented where glipizide caused it, according to the research here in dermatology. That was, and it's an old publication too. So it typically happens with your first generations sulfonamides, which are your antibiotics.
So then I wouldn't worry about the glipizide as being a sulfa, or would I? Because I had a question on it, but I wasn't too sure.
I did not think it contained it, but it's saying it's a second generation. So give me a second. So according to this, it says sulfonylurea medications that may be okay with a sulfa allergy are your diabetic medications, your glyburide, your glipizide. Imitrex is okay. I mean, it's not, it's saying it's okay if you have a sulfa allergy. Again, I only saw that one study, but that was just a quick review of looking through the literature of a case of Stevens-Johnson syndrome.
Okay.
So what was your question? I mean, like, what did the question ask you?
It was saying about glipizide and being a sulfa drug. I didn't get it, so it didn't give me the right answer. So I guess I don't know if I got it wrong, but that's what I was wondering. Is that also one that would cause it? The glipizide and the glyperide.
Yeah,
Like all the
like I
ides.
said, it only gave me one study, and that was from 2006. So that was a long time ago. If you come across that question again, let me know, because I'll have to change my teaching. But
Yeah, I was just like curious about it.
yeah,
'Cause I must
most
have not-
often your Stevens-Johnson syndromes occurs with, and it can occur with anything. I had any kind of chemical, because it's a skin reaction. I had a patient back in the 90s when I was working in the ICU. She was an African American patient and went to the hairdresser, and they put some kind of chemical on her head and her hair, and she wound up with Stevens-Johnson syndrome. And unfortunately, it, because that leads to multi-system organ failure. She was there for about 3 weeks and she passed away. But towards the end, it was like her skin was like completely shedding, and she was African American and she looked white because the pigment layers and everything was just, I mean, she had it really bad. She wound up being on the ventilator the last week of her life, and no matter what we did, nothing helped her. But so sorry I couldn't answer that completely, but I would have to do a little more research on that or look at the question.
So Steven Johnson is that rash that peels skin, right?
It can, yes. Steven-Johnson syndrome is a bad skin a rash and skin allergic reaction to chemicals most often. And and your medications are chemicals, but it's most often occurs with antibiotics, vancomycin, and your sulfameds. Any other questions? Well, thank you guys. That was good interaction tonight. I like it when people talk and ask questions because I don't want to be the only one talking. If nobody has any questions, I hope you all have a great night or day, wherever you are.